Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds series. My name is Joe Saramelli, and I oversee Grand Rounds for our department. So here, today's our the first presentation in 2024, continuation of the series, but first of the new year. I'd like to encourage you to write any comments or questions about today's presentation in the chat or the Q&A. I can go through those at the end with today's presenter. There's a group of us that works on Grand Rounds throughout the year, including Semhara Braha, Mike Walker, and Charles Borio. There are several sources of funding for this academic year's Grand Rounds series, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, the Treatment of Mood Disorders Fund. So a couple of points about Grand Rounds, and with that, I'd like to introduce today's speaker. Today's presenter is Dr. Daniel Jimenez, who is an associate professor of psychiatry and behavioral sciences at the University of Miami Miller School of Medicine. Dr. Jimenez completed a PhD in clinical psychology at Pacific Graduate School, and then went on to some really specialized research training in geriatric mental health services at Dartmouth Medical School. And this has led to really, I think, a sustained focus on research in aging and on mental health services for older adults, including with evaluating the effect of exercise on prevention of anxiety and depression in older Hispanic adults, and a current ongoing large-scale trial that's testing health promotion activities in older Latino adults. Really just a summary of things. We'll hear about a large body of work today during the presentation, but I want to mention one other point because I've done a lot of these types of introductions, and I have to say I'm not always handed or have an opportunity to read an autobiography by the presenter, which I had a chance to do earlier today. I have it right here. It was published in the American Journal of Geriatric Psychiatry, early 2021, so a couple years old, titled "An Academic Looks at 40." So an update might be a couple years beyond that for today, but I want to quote from it just one line Dr. Jimenez wrote, which is regarding thanking mentors, that they recognized that who I am directly influences what I do, and this has allowed me to, one, ask the questions that those around me are not likely to come up with, and two, answer those questions taking into consideration the impact of culture. And it's a reflective way to think about a mentoring relationship and developing research skills. And I'm really looking forward to hearing the research program and results that have come from that. With that, I'll turn it over to Dr. Jimenez.
Thanks, Joe. I appreciate it. And yeah, the autobiography was an ask by one of my mentors, Chip Reynolds, who's the editor-in-chief of the American Journal of Geriatric Psychiatry. And I was a bit taken aback when he asked me, because usually that's reserved for people of high standing, or at least with a lot grayer beards than I have. But nevertheless, it was one of the greatest. It was a great opportunity and a great experience to be able to do that and to be able to share my story. And I want to thank you and Jürgen for inviting me to be part of this. I've known Jürgen now for many years. I was part of a T32 training fellowship that was at the time had 3 sites. There was one at Dartmouth, one at Cornell, and one at Seattle. And there was a lot of cross collaboration between the mentors and then also between some of the T32 fellows. And while I never made it out to Seattle, it was always sort of a dream of mine to do so. And hopefully in the fall, because the Gerontological Society of America is having their annual meeting there, so maybe I'll be able to do that. But today I wanted to talk to you about some of the research I've been doing surrounding older Latino and using health promotion to prevent anxiety and depression in this population. And so I have no relevant commercial relationships to disclose. My bank account will definitely attest to that. Although my kids would say that say that my work is definitely in conflict with their interests, because a lot of this work was done when they've been home because of school being because they were here because of the pandemic or what have you. And so I was having to try to juggle them as well as trying to do my own work. And so sometimes that's what they would say, that my attention was a bit scattered. Okay, and I do want to just acknowledge the people who have helped me get here and who actually do the work that allows me to do this presentation like this. And Natalie Ferris, Orieta Fontang, Alexander Rivera, Daniel Barba, Elizabeth Soriano, and Doris Perdomo Johnson, who have really done a phenomenal job, just recruiting and implementing the intervention, and really being that the true liaison between the ivory tower that is academia and the actual real world. And so I want to start off with the Hispanic or Latino. We often hear those two terms, and they are often used interchangeably. And is there a difference? In all honesty, I don't know. That's probably an anthropological question. I was born and raised here in Miami. My parents are Cuban. Here in Miami, I grew up using the term Hispanic, but then I went to California to do my graduate school, and then folks out there used Latino. So I was using Latino, and then I moved to Texas, and then it was Latino. Latino was the preferred term there. And then I moved to when I moved to New England, in the Boston area specifically, they use the terms Latino or Hispanic sort of interchangeably. So I think it's just my personal opinion. It's just a matter of geography where you are. It's just a matter of what term the people are using in that specific area of the country. But for consistency's sake, I will use Latino, or at least I will try to use Latino. Like I said, I've been everywhere, or at least here in this country, I've been to so many different places, and I've had to switch back and forth. That while I will try to use Latino to be consistent, I am in Miami. I was born in Miami. I was raised in Miami, and so I might fall back into using the term Hispanic. So I do just know that we're talking about the same people. And so who are these folks that I'm talking about, right? Who are the Latinos? And at present, there's around just under 61 million Latinos living in the U.S., and which make up a little under 19% of the total U.S. population. And the U.S. Census Bureau defines Hispanic or Latinos as an ethnicity comprised of individuals of Cuban, Dominican, Mexican, Puerto Rican, South or Central American, or other Spanish culture or origin, regardless of race. And so during this presentation, when I am referring to Hispanic or Latino, I am referring to those countries, specifically those Spanish-speaking countries in Central and South America and the Caribbean, including Puerto Rico. And so who are these folks? And what does this enormous population look like? And this is a very heterogeneous population. The majority of Latinos living in this country are of Mexican descent. Almost 2/3 of that population, of the Latino population, is of Mexican descent. Second is Puerto Rican. And then I did not realize this when I was growing up here, because everything was so Cuban-centric here in Miami, that I thought Cubans must be like a large percentage of the population, of the Latino population. It turns out, nope, that they're only about 4%. Here in Miami, it's not like the rest of the country, because here in Miami, the majority of the citizens of Miami are actually Latino, and the majority of the Latinos living in Miami are of Cuban descent, and followed second by Colombian, and then third are Venezuelans. So with the rest of the country, the predominant Latino sub-ethnicity is Mexican. Here in Miami, it's not that at all. So which made it very interesting to go from Miami to California, and then seeing and being able to experience those intra-ethnic differences, which I was not aware of when I moved. as you can see, Latinos are not a homogeneous or a monolithic group, and each Latino subgroup has their own cultural heritage. For instance, in Central and South America, Mexico, they have a large Native American Indian population or background and cultures surrounding Native American practices. Whereas if you go into the Caribbean, predominantly African, with much less Native influences, but more predominantly African. And then if you go down even further south into Argentina and Uruguay, you see a very much large European influence, specifically Italian and German. And so while we all speak the same language and we are predominantly Catholic, we all have our own unique backgrounds, our own unique heritage, our own unique practices that shape each one in the individual. And then also we each face our own unique difficulties. So for instance, Puerto Ricans, they typically don't have problems with immigration or legal immigration, but the dual identity is a problem in the sense of, like, are you Puerto Rican? Are you American, quote unquote, and treated not like one or the other. And with Mexicans, right, with a lot of Central and South Americans, it's about the difficulties in immigration and trying to cross the border and fear of deportation. And so growing up, I didn't know any of that. I was not aware of the dual identity problems. I wasn't aware of the legal immigration difficulties. And because Cubans, we didn't have the issues necessarily around immigration, because once they got here, they were given a path to residency. And so it was interesting to go clean, from Miami to California, from California down into Texas, and to understand how, while we do have a large interconnected background of ancestry, with common values such as familism and common religious practices, but there was a lot of things that differentiated us and made us different. And so I try to, in the presentation, I will try to take into account the differences with the ethnicity, but I will mostly be talking about the population as a whole in aggregate, because there's just the national samples that we have available to us do not allow us to make huge differentiations between, let's say, Mexicans and Cubans and Mexicans and Puerto Ricans and Dominicans and the like. And so some exciting facts. I'm a big fan of puns, much to the dismay of my children. In aggregate, Latino adults are at lower risk for most psychiatric disorders compared to their non-Latino white counterparts. However, a much more complicated picture emerges when you take into account age and sub-ethnicity. And what do I mean by that? Overall, what we find is that the lifetime prevalence in Latinos is about 16.4% as compared to 12.2% in white. The lifetime prevalence of anxiety disorders is about 15.3% in Latinos compared to, and these are all older adults, by the way. 13.5% in non-Latino whites. And then when we move into the 12-month prevalence, we're looking at about 8% of prevalent depressive disorders in Latinos compared to 3.2% in non-Latino whites, and 12-month prevalence of anxiety disorders, 9.4% in the 12-month prevalence of anxiety disorders compared to 8.4%. But this is what I'm talking about. When you take into account sub-ethnicity, you start to see the sort of the differentiation, whereas Puerto Ricans they're the ones pushing that 16.4% higher, and the Mexicans are pushing it lower, and the Cubans are sort of in there. We don't have on anxiety disorders for children. But studies that we see for results, they have disorder have the low prevalence of anxiety disorder in the middle. And don't have we have data of sub-ethnicity such as Dominicans, Venezuelans, Colombians, and the like. So country of origin alone does not confer risk or protection from psychiatric illness, and rather it's a complex combination of risk and protective factors. So there's the family and how much and whether there's a social support network upon immigration, upon immigrating, contextual factors such as SES and immigration. Sorry, I had COVID not so long ago, or actually no, it was a long time ago, and ever since then, I've had this brain fog, and it comes up every now and then. It's been happening, so I apologize if I keep stuttering. It's just I've been having word finding difficulties, but nevertheless. And then age of arrival plays a very critical role in conferring risk or protection upon immigration. And the younger, if you are below, it's been shown that Latinos who arrive to the U.S. prior to the age of 7 have a higher risk for developing psychiatric illness, whereas compared to if they arrived in the U.S. after the age of 7. But if they arrived after the age of 35, then that risk increases back again. And so folks like my grandparents who came in well into their 30s and 40s, actually they were into their 40s and 50s when they arrived here. They had a very difficult time trying to assimilate because they just couldn't. They couldn't. It was very hard for them to grasp the language, to learn how to speak English, and so it became a thing where they were very much close, and because communicating people who are and so it made it very difficult for them. So there's this need, as we've shown, that there's presence, but yet that need, older Latinos are just not the same as Latino. What we found is that about a quarter of older Latinos who have demonstrated need actually go and seek treatment compared to about 30% of Latino white. And their language, income, insurance, differences persist, access similar. And with that, even services, although the kids they tend to receive quality or inadequate treatment. Why do these disparities exist? If the services are there, are available. Well, most racist that whole other topic that we discussed for a very, very long time. There is this component to, and that's the they don't match Latino's experience of, and so it's professional and the research done and it's clinical and the patients that I've worked with, I describe their physical symptoms. So say,
Daniel?
the chest, like I'm drowning, it's pain, there's illogical. And so when they're asked, "Hey, well, come on, and we're gonna do this together," like, wow, oh, like
Hi,
physically
Dr.
speaking,
Jimenez.
because I
Hi,
and
sorry to
so
interrupt.
sitting on the couch, got bothering them without getting any sort of help, at least from what they perceive. It's just not matching. So it leads to that dropping out of
Daniel.
so
Daniel,
what other issues are behind these disparities? The driving factor is that they always just have to believe about what causes mental illness, and so believe mental illness cause of friends issues and moving to different places. Right? There's no migration tearing that if they would have stayed in their home country, if they would have been surrounded people that they love, that feeling that they would not be, and not only in society, but themselves, that the effect of the scattering of family is traumatic and leads to health. And there's stigma. As soon as we talk to like my aunt, and if you talk to them, no, so not easy, and it's it's a clear area that inhibits them from talking about actually bothering them, because if they were actually how the feeling, it and it would change to the family, and it would be same investment to them as well, because if they go to work and they're feeling, which is a real illness, they then believe it's a place of their family, right? That, you know, they because feeling depressed, and it looks wrong. You just work, and and something there is just that right, there's something with me now, and it's enormous internalized stigma. Just a health very seeing that any sort of medication leads to control. That's very common, at least in the patient population and the research participants dealing with it. So we've.
Hi, Daniel. Can you hear me? Daniel.
I don't minimize. These are significant.
Daniel. Yeah. Can you hear me?
I can't.
Yeah. We're having your audio is breaking up a lot.
Hello?
Yes, that's good.
We're good?
It sounds better so far. Let's see how it goes. But for the last couple of minutes, it was really breaking up a lot. Yeah.
Oh, I'm so sorry. I'm so sorry.
This sounds a lot better. Let's see how this
Okay,
goes.
so we'll just go like this.
Thank you.
Yeah, technology, gotta love it, right? Sorry. Let me get back to it. So the show will move on. So we've talked about a lot of the problems, and they are significant. But I want to be an eternal optimist here and say that the sky's not falling. We can do something about it. And so what can we do about it? And the way I've gone about addressing some of these problems has been health promotion. And so what I mean by health promotion is that these activities or interventions that maintain or improve well-being. So this could be diet, so working on nutrition, exercise, staying physically active. It could be working on sleep. It's these types of activities that aren't necessarily addressing directly, let's say, depressive symptoms such as, sadness, right? Like it's not psychotherapy per se, but these are interventions that go about it in sort of in a different way. And we have found that the health promotion activities, they reduce vulnerability factors. We know that they're effective in reducing depression, anxiety symptoms. We know that they improve physical functioning. We know that they improve sleep. They've been used to improve psychosocial outcomes such as self-efficacy. And we've seen also that they reduce biological markers such as inflammation. And the good thing about health promotion activities is that you sort of kill two birds, one stone, because you also address some of the physical health disparities that older Latinos also experience. So diabetes, obesity, and heart disease are all highly prevalent in this population. And older Latinos are the most sedentary group of any racial or ethnic group in this country. So I've gone up, and so how I've done this is I created the Happy Older Latinos Are Active, or HOLA, and it's a multi-component health promotion intervention where participants they meet once a week. They meet first with the interventionist, who is a promotora or a community health worker, for a physical and activation session, and that's a one-on-one 30-minute session where the promotora talks about or gives them information about the intervention, talks to them about mental health, talks to them about physical health, and then they come up with a sort of list of goals that they want to achieve, and then they come up with, or they problem solve potential problems that they can see, that the individual can sort of see coming down the line, that's going to prohibit them from actually engaging in the other components of the intervention. And so then they come up, not only do they brainstorm what the problems could be, but then how to overcome some of those obstacles. And then the second component is a moderate intense group walk for 45 minutes, 3 times a week for 16 weeks. And so then a group of 6 participants meet with the promotora at a centrally located park here in Miami-Dade County. And the promotora leads them for the first 10 minutes in a stretch warm-up. And then the next 25 minutes is followed by a moderate intense walk, where the 6 of well, in this case, it's a group of 7, right? 6 participants and the promotora, they walk in the park. It's not a leisurely stroll. It's meant to get your heart rate up, and for 25 minutes, and then for the last 10 minutes, it's a stretching and cool down. And then during that stretch cool down phase, then the promotora leads them in a pleasant event scheduling during and what I mean by that is that the promotora asks each individual, okay, what pleasant event, anything that you like to do, anything, just something that you like to do, just say what it is. And then it could be something very sedentary, it could be something very active. The only thing that we say is that it has to be done with another person, because we're trying to reinforce not only the physical aspect of it, but also the socialization. So it's this physical and socialization combination. And so we compared that to the photonovela. And the photonovela is an educational book that's been used to educate Latinos on a number of issues, such as diabetes, nutrition, cancer, all sorts of stuff. And what it is basically, it looks like a comic book. And I'll show you a picture in a second. It looks like a comic book, but the quadrants, or the little the squares that would be sort of drawn in a comic book, are actually they're still photographs, and it looks like still photographs from a telenovela. That's why it's called photonovela. And so the stories tend to be educational, but also like they depict very sort of very stylized, sort of overly dramatized scenes to get the story across. And it's a way of really addressing or educating this population in a way that is very culturally appropriate, but also in a way that's going to allow for folks with low literacy to be able to understand as well. And we chose it as a control group because it was non-activating as compared to the OLA group. And so this is what one page looks like. As you can see, they're still photographs of actual people, but it's in English and in Spanish, and it looks like just a normal scene as they would have seen in a telenovela. And so this was a pilot study where there was 60 participants total, age 60 and above. They all self-identified as Latino. They had to screen positive for either on the PHQ-9 or a GAD-7. They had to get medical clearance from their PCP, and they could not meet criteria for major depressive disorder or generalized anxiety disorder. They had no history of SMI and no history of substance abuse in the last 12 months, and also not taking psychotropic medications, because this was meant to be a prevention intervention. So these are folks that were it's an indicated prevention intervention where the folks had already had some symptoms but did not meet criteria for major depressive disorder, GAD. And so it was a pilot trial. So our main outcomes were feasibility, defined by 100% getting our recruitment with 20% or less of eligible participants refusing randomization, 85% completing the post-intervention assessment, and then 80% of sessions being attended by the participants. We weren't powered to detect differences. To do a true prevention trial would have required a lot, a huge sample, and this was part of my K award. So a $50,000 budget does not go, $50,000 a year does not go very far. And so we tested them at baseline and post-intervention. So this is what the sample looked like. 56%, or about 57% or so, were from Cuba or of Cuban descent. A third of them were from South America, Colombia, Venezuela, and the like. 3% were from Central America, 3% were from the Dominican Republic, and 3% were from Puerto Rico here in the US. And so we were really proud that we got this sort of nice, smattering, because in Miami, 2/3 of the Latinos here are Cuban. And so the fact that we were able to get a bit more diverse sample was a bit of pride for us. And so the average age between the two groups was about 71 or 72. There was no differences in age or years of education. And we did find differences in the years in the US, mainly because the folks that were from the US happened to be randomized to OLA as compared to the fotonovela. So we were able to meet with an army of two. I'm happy to say that we were able to meet our recruitment, our 100% targeted randomization. 56 participants completed, or 93.3% of the sample completed the post-intervention assessment. 3 participants from control and 1 from OLA were lost to follow-up. And just under 70% of the sessions were attended. And we had a huge range, as you can see. And that's because one person, she dropped out after the first session because she felt that she was too overwhelmed. And, so she felt that she couldn't do it. And then another person had attended 2 sessions, and they stopped after the second session because they actually got a job. So we weren't, like I said, we weren't powered to detect differences, but we were trying to see, can we find any sort of differences even within the small sample that we looked at? And what we found was we didn't find any changes from T1 to T2 between on the quiz, which was the quick inventory of depressive symptoms between the two groups, what we did find was that there was some signal for us that we felt very positive on, looking at group differences between baseline and post on the BAI. And so then what we decided to do was we decided to look at, could we look at clinical significance instead of seeing statistical significance? One of my mentors recommended that we look at clinical significance, which he had done in some previous studies of his, and the way he had defined it was a reduction of 1/2 the standard deviation of the scale score at baseline. And what we found was we found a trend for the quiz, and we found significance for the BAI. So we were feeling very high, very positive about about our results, and that we had detected at least some difference. So we were very happy about that. And so that then turned into an R01 that we are now currently doing. And while we were thinking about, okay, that we're moving on to the R01, we got the R01, now that's out in the field. And so like, what else can we do that this intervention has multiple, like we said, it addresses multiple issues. So what can we do how can we expand upon this intervention? And so I partnered with colleagues of mine at the University of Miami who work with folks that are living with HIV or AIDS. And when I was talking to them, the issue of aging with HIV started to come up. And I was like, well, is anybody doing aging work in HIV? And so the overwhelming majority of people told me that no, that there's not a lot of people doing and that are looking at this. And so the more I started digging, the more I started realizing, wow, that this is a huge need, because Latinos living with HIV are uniquely at risk for deleterious neuropathological and neurocognitive sequelae within the context of aging. So we know that neurocognitive disorders happen earlier in folks with HIV, and older Latinos are even more affected because they're starting to show signs of neurocognitive decline earlier than even than folks with than non-Latino whites with HIV. And in this population, depression is 5 times higher than in the non-HIV population. Anxiety is seen as 8 times higher. There's a population that it suffers a lot from loneliness, isolation, stigma, and is also very, very highly sedentary. So what we did was that it was another pilot. So we were trying to assess the feasibility and acceptability of OLA in a sample of older Latinos living with HIV, and we wanted to see if OLA can improve psychological and cognitive outcomes amongst older Latinos living with HIV. And so this was a 1-year study. This is $250,000. It was a supplement that we got off of a colleague's R01. And so we were able to get 30, we targeted 30 folks, age 50 and above, who self-identified as Latino. They were living with HIV, but were virologically suppressed, and they were stably housed in Miami-Dade County. They had to get medical clearance from their PCP, and they were recruited through a consent to contact database, as well as word of mouth here in Miami. And these are, I'm trying to be mindful of the time, but these were the measures that we used. And so the sample was roughly, on average, about 62 years of age. We had, the majority of them were male. The majority of them had a high school or greater, but it was almost half of them did not complete high school. A little over half identified as straight, but there was a very large, about half of them also identified as LGBTQ or I. As you can see, ethnicity, we had folks from Cuba, Puerto Rico, Honduras, born here in the US, like on the mainland, and from Nicaragua. About 38 years in the US, and they all spoke Spanish. It was all done in Spanish. And so in 7 months, we were very happy. We met our target enrollment with less than 5% of eligible participants refusing to participate. We had 3 participants that were lost to follow-up.
And we had about 54% in terms of participation or attendance in the in the in the OLA. But what I think was very telling is that when we talked to the individuals, when we talked to the participants, we asked them like, well, what did you like about it? What did you like about this, about the, or not, you know? Please be completely honest. And the overwhelming feedback that we got was positive. And then the themes were pretty much surrounding overcoming social isolation, loneliness, and stigma because of the group walks. Like one person said, when we talk, I am entertained, I enjoy the company. I like that I can talk with the group and share how I feel. My friends in the group are like family. So the groups started to coalesce around each other. Whereas they felt beforehand, they felt very much isolated and lonely and not and hesitant to engage with other folks because of either their sexual orientation or because of their HIV status. But then also there was this bit about physical activation, that they felt that it was they really enjoyed being able to get out, to be able to walk. Like one person said, I like to walk and interact with other people. I also like how it clears my mind. The notion that like this activity can help sort of clear your mind and be able to and have mental health benefits was very clear. And so but then we also looked at the neurocognitive measures, some neuropsychological measures, and what we found was we found initial effects on delayed recall, on Trails B, on FAS, verbal fluency, on depression and anxiety. And then what we did was we looked at, okay, well, these are, or we found trends in Trails B and then trends on the verbal fluency. And so we said, okay, well, what if we adjust for age, sex, and education? Do we find any differences? And lo and behold, we found statistical differences on delayed recall, Trails B, verbal fluency, depression, and anxiety. And as my wife, who is a neuropsychologist, was very quick to point out, she was like, yeah, it was probably practice effect. And I was not very pleased with her, raining on my parade. But I was happy that we did find something, and it may be, but that's a question for the next iteration of this. And so we're in the process of writing this up to submit now in May, because a control group would definitely tease that apart. But we were nevertheless still, despite my wife's quip, we were still very pleased with what we found. So the nuance window, it's great. We found decent. We through our pilots, we found some good indicators. We found some signals, but they were pilots. I get it. And some of these, and in the Michael Award and then this OLA and the OLA HIV pilot, the attendance missed the mark as we were and it wasn't what we were hoping. But when I started to delve down, when I started to ask, like, well, why is this not happening? Why, like, what's happening with the attendance here? Turns out the real world got in the way, and I didn't realize this, but inflation has been playing a huge role in affecting participation, at least on our end, because gas prices, simply put, folks had to decide whether they were going to drive somewhere, and if they did, that meant that they couldn't drive other places, right? So they had to ration where they were going to go and where they were going to drive, because gas prices were so high when we were conducting at least the OLA HIV pilot. We were encountering this, that they had to decide they had to decide what their priorities were and where they were going to allocate their very limited resources. And for some participants, they had to go back to work. Like I said in my K Award, one participant actually had to go back to work. And then in multiple participants, actually, in the Ebola HIV trial, had to go back to work because they simply could not afford to keep up with rising prices on everything, rising rents, and here in Miami it's gone through the roof. Rising rents, gas prices, rising food costs, everything, and so they had to go back to work, and so that also impacted. But as one of my community health workers like to say, it's not that they chose not to do this, it's that they would go once, right? Instead of going to 3 times a week, they would go 1 time a week because that's what they could afford to do, basically, in terms of time and in terms of being able to allocate their resources into doing it. But their motivation was to do more, but they just couldn't. The technology divide is very, very real. Folks here had flip phones, so getting in contact with them was kind of difficult at times because they oftentimes would use those pay-as-you-go phones, and so we could not get a hold of some of the participants for the first week of the month because they had not paid, or they were waiting for their check to come in so they could pay for the next month of cellular use. The virtual serves to complement the in-person. There was a huge pushback on doing anything virtual. They wanted to do stuff in person, face to face. And COVID-19 definitely exacerbated the social isolation and loneliness of folks that have or are experiencing lots of stigma, that are experiencing, that are experiencing stigma, that are experiencing, some sort of shame or embarrassment about who they are and about how they're feeling. And so it's like COVID-19 sort of just made a terrible situation even worse. But despite all of that, from all the feedback we've gotten from all the participants, whether they were in the K-Word pilot or whether in the HIV pilot, we got incredible feedback from the participants, how much they enjoyed, how much they took away from, and how much they hope that this type of program would continue in one way, shape, or another. And so the implications of it, that I think we can all take from it, that we have scarce resources. There's no way around it, and especially when we're dealing with highly marginalized individuals, but we have to be efficient in how we use those resources, and being able to combine prevention efforts, whether it is preventing diabetes, whether it is preventing cardiovascular disease, or preventing cognitive decline, let's say, or cognitive impairment, to combine our depression or anxiety efforts with those other efforts, because trying to kill as many birds with as little stones as possible. And then also using or looking towards alternative service delivery models. We use community health workers or promotoras, similarly to how Vikram Patel and Chip Reynolds used them in India in their Manas trial and their Dil trial. It's a way to sort of extend the reach of what we do without having to pay for a psychologist, or without having to pay even a nurse practitioner, or without having to pay a psychiatrist. And also, health promotion interventions they're not just for Latinos. They can be very useful engagement tools for hard to reach or underserved populations, no matter if they are Latinos or if they're African Americans or even Asian Americans as well. We've shown that health promotion interventions, they are less stigmatizing. They're very salient because these are folks that are having to deal with things like diabetes, cardiovascular disease, hypertension. And so to be able to do something, to go out for a walk, I think really sort of speaks to them. And because of the promotora model, it can be widely disseminated. And with that, I am done. And I will stop sharing.
Well, this is very, thank you for presenting this through the numerous trials, through next steps. It's very interesting to me. I guess before I make a comment, I'd like to encourage any participants to write in comments or questions. We do have a few minutes to go through things. It's interesting to take what's common clinical advice and add structure to it and help to increase the likelihood that it occurs, like exercise. walking, social interaction. And it made me wonder how often that advice is taken up without such a structured approach. And I don't know. Are you aware, Daniel? I wonder, without this sort of structured approach, is it unlikely to occur?
So it's interesting you say that, because I cannot say for sure, right? Because I haven't looked at it systematically through research or anything, but I can tell you clinically, it's impossible, right? Like getting folks to be behaviorally like I'm behaviorist, right? I do behavior activation. When I talk about health promotion, I live it, right, as a clinician. And when I talk to them, I'm like, okay, let's set it out. I'll even lay out like, okay, on what they can, we go out through their schedule. And I found like their homework comes undone, right? If they come back and I'm like, I didn't do it. I'm sorry, doc. I'm like, okay, that's fine. What was the issue? Why couldn't you do it? But without that structure, without that, that accountability partner, if you will, right there saying like, no, you're going to come with me, and then this whole group is going to be there, right? So then the group sort of then adds to that accountability. Then that's when it happens. But without that, it becomes very, very, very difficult. At least I have found clinically.
Especially with sustaining.
Right.
Yeah. And another thing came to mind as well. And again, if there's others with comments or questions, please feel free to write in. We have time to go through some questions. You as a psychologist, would you oversee several of the groups? Is that how that might work? Is that kind of like a caseload? Is that a way to think about it?
Very much so. Yeah. Where, and that's what we would do. One day a week, we would have our team meeting, and then we would go over the groups, Alex, what is your group? And he would talk about his groups, and then we would like, what are the challenges, and who came this week, and and then we would go through that, and like we would supervise, and I provide supervision basically. And so I mean, one day a week of mine was spent doing that in this, and it's not a whole day. It was basically like over the course of like our team meetings are about 2 hours. But then like, if you think about it, like how many people then are they then impacting, right? And it's like out of one person, me, like I'm supervising all these folks, and then they're able to be in the community, they're able to then do, and then they're able to see all these folks and make a lot more than I could. Look, I'm only seeing patients. I see patients on Tuesdays, and it's 8 patients that, right? Like that's a little bit more than one group, basically.
Mm-hmm. Yeah. I wonder too, if this is not just a research question, but kind of recruitment into that intervention as it's a group intervention. I mean, people talk to each other. Do you see sort of interest? I don't know if people, I have a friend who might benefit from this, something along those lines.
Yeah. So when I said that that the recruitment for the HIV pilot, it was done. When we wrote it, it was designed like we had put in that we were going to use this database, and what we ended up finding was we'd recruit one, and then another person, and then like, oh, I got this friend of mine. Can that person? And we're like, sure, as long as that person 60 years old. Yeah, the person's over 60 or over 50 in that case. All right, and so then like, they would give us their number, or they would or the person would then call, and then we would screen them. And so we had a really like a good mix of folks that came in through word of mouth, and also because of through the consent to contact. But that has been a very powerful thing. But also within the group, people have come and they don't know each other, and then over the course of the weeks, they'll be like, either when I was talking about the transportation issues, like it was a big thing. And so what folks ended up doing sometimes was they would carpool, even if it was just like 2 miles away. So it was like, oh, it's my turn to drive today. And so that they'll take like two or three people from the group, right? And so then they would go together. And it's like, oh, it's my turn to drive today. And so then that was a way for them to be, to still stay together, and still be able to maintain going to the groups when like otherwise they would have been out of luck.
Yeah. I'm thinking about two kind of, I don't know if this is the right term, implementation type things. One is a little bit of a joke, is implementing this into a cold, rainy Seattle winter. uh, Clearly we have sunlight like on today. But the other maybe is how, I mean, maybe as you're analyzing results from the R01, this might be clear, maybe it's a next step, but bringing this into a healthcare setting, like making it more typical, I suppose. And would it be in primary care? Would it be in mental health clinics? What, yeah, how do you see that going?
Yeah, so yeah, it's something that I've struggled with because I'd love to see it move beyond. And then there's a couple of things. One is that one of the location is a big deal, but more I think is the model as because there was a movement when I moved down back to Miami 9 years ago. There was movement to have this certification process of the community health workers to have this really standardized way so that folks can become a community health worker. It meant something, and they can then with the goal being that eventually they would be able to bill for their services. And so that I think is the biggest hurdle right now is in like how are we going to pay for these folks? And then until that, if that also, in addition to the where are they going to be located? Is it going to be like a primary care clinic? And I think it would fit very well in a primary care clinic. Could it be in a more specialty mental health clinic, or could it be could it stand like at a park, right? Like with some supervision or what have you. But nevertheless, until that community health worker, until that thing is figured out, it's hard for me to see like how this would be sustainable, even if we figured out like where they would be.
It's a very, very interesting point. Yeah. It's a lot to think about.
Yeah.
Yeah. Perhaps the results of this trial will be persuasive in those efforts as that community health worker part is figured out. Anyway, well, Dr. Jimenez, thank you for presenting today. We're just out of time. There was a comment that came in, I think, as I was asking that last question about thinking about cognition for individuals without HIV as well, maybe with vascular risk factors and so on. Just maybe broadening out the population. And this person's very interested in seeing what you continue to do.
Yeah, and so just one little point about that is like last year there were 2 reports came out showing that folks that had stroke, that they suffered a stroke and then subsequently recovered from a stroke, and also a heart attack, or who had a heart attack and then recovered from the heart attack, they were at like their risk for developing cognitive impairment increased like exponentially. And so with the new recommendations, it's relatively new recommendation of folks who have TBI get them physically active, that I think that there is room for that expansion to happen. And so that was another avenue that I'm trying to pursue as well, is could we look at cognitive impairment, vascular health, and mental health, sort of like that sort of constellation.
Yeah, things that cluster together. Yeah, very interesting.
Again, you have one stone, so what can we put together?
Yeah. Well, very good. Yeah, it's again, thank you. This has been very informative, interesting to think through how to structure this, like we've talked about, seeing the results and really hearing a lot about trial design decisions as well. So thank you for presenting today in our grand rounds.
Sure, and thank you for inviting me. And I apologize about the audio, like that was unfortunate, but hopefully I'm glad we were able to catch it, and hopefully not too much was missed.
I'm glad too. Yeah, and it was good. That was a couple of minutes, and then it improved a lot.
Okay.
So, all right. Well, with that, we'll end grand rounds. So,
all right. Thank you.
Thank you.
Bye.